So Ahmed, I wonder if you're there. I think we'll go ahead and start the uveitis session then. So we're starting in time. Let me have here.
Hi.
All right, we have here, let me just introduce the session. We got it. Okay, excellent. Okay, well, welcome everyone, and it's a great honor to be here. My name is Ahmed Salam from the University of Arkansas, and I would like to thank Al-Qasimi meeting and Dr. Al-Amri for the kind invitation. We have the first uveitis session here, and we have a great panel of world leaders in uveitis. So I'll introduce the panel. So our panel, our first speaker is Dr. Hassan Al-Dibi. He's a senior academic consultant and the chief uveitis consultant at Kekash Eye Specialist Hospital in Riyadh. And then we have other speakers who are with us here. We have Dr. Shri Kurup, and he's a vitreoretinal and uveitis specialist and the head of the retina and uveitis in Cleveland Hospital in Ohio. And then we also have Dr. Rola Hammam from Lebanon, and we have Dr. Lamri Hasnaf from Morocco, and sorry, I apologize, and Dr. Armando Oliver from uveitis specialist, and he's the head of the department in Puerto Rico, and Dr. Samir Chowki, uveitis specialist from Egypt. I hope I didn't miss anyone. And is Dr. Yes, and I can see Dr. Al-Amri here. Dr. Al-Amri, do you want to say something before we start? Thank you for the kind invitation.
Thank you very much, Dr. Ahmed. Just I'd like to say hello to everyone and thanks everyone for giving us the chance for learning from their experience, and thanks a lot. The mic with you, please.
All right, excellent. So our first speaker, Dr. Hassan Al-Dibi. So we'll have the case, and then after that we can have a few minutes of discussion, and we keep moving on. I think the important points are always comes up in the discussion. Dr. Hassan, great to see you, and thank you so much for being here.
Me too. Good afternoon. Thank you, Dr. Ahmed Salam and Dr. Al-Amri for your kind invitation and give me the chance to participate with you in this webinar tonight. So I'm gonna to give you a case that need to have some attentions and integrations between different subspecialties, including uveitis, medical retina, and surgical, and rheumatologists. So let us to go without any ado. So my patient is 17-year-old, medically free. His referral cause was vitreous hemorrhage, occlusive vasculitis left eye, with complaint of decrease of vision left eye for 1 month. He is known to have asthma symptoms on and off, not on any treatment. He had a history of positive tinnitus, hearing loss 1 month, otherwise negative systemic review. His vision, ocular examination showed that vision in the right eye is perfect 20 and left eye 2400. The pressure was within normal, and his color vision as well in the right eye is normal and reliable in left eye. Examinations of the anterior segment was within normal in both eyes, with occasional cells in the left eye. And his posterior segment examinations of the left eye showed that mixed vitreous hemorrhage, extensive neovascularizations, fibrovascular membrane at the disc and extended to the inferior temporal with sheathing, as you see in these pictures. The picture looks like a bit ugly with the vasculitis, as you see in the inferior temporal area extending from the disc. And striking feature is in this picture. If you can focus in the mid of the macula, there is an area, looks like, and retinitis rather than to be an cotinal spot. So this patient at this times, and this is the fluorescein angiography of that patient. You see that area of the fibrovascular proliferations with the vitreous hemorrhage all over and non-perfusion of the inferior temporal area. Again, you see just only mid-phase, and you see how much that an aggressive fibrovascular membrane proliferation with the non-perfusion in pleurotemporal. And you see a little bit of staining at the area between the perfused and non-perfused retina with little bit staining and leakage. This is an obvious late phase, and there is an all of that diffuse leakage from the background of choroid. Other eyes completely normal. This is the OCT of the left eye, and as you see, there is elevation of the retina with subretinal fluid. So the patient at this time starting to be investigated through labs where BBD negative, CT scan of the chest were normal, MRI brain were negative, angiotensin converting enzyme, HLB 51 and 27, syphilis, ANA were negative. So at that point, the patient were underwent BRB left eye, but was limited by vitreous hemorrhage. In the same times, other investigation which taking time were performed and show that anticordial negative and B2GB1 is negative as well. Factor 5 leading polymerase mutation is done as well in this patient and absent for mutations. Protein C function was within normal, and B ANCA to C ANCA were negative. The patient referred to rheumatologist to rule out connective tissue disorders, and the feedback was no signs visible from the present from the connective tissue disorders. And this is his pictures just only after 2 months of that, and you see that the progression of the disease with more vitreous hemorrhage and proliferations at this stage, as you see here. So this is 17-year-old with the poor vision now in the left eye. This is the his FA, and show that limited, bad retinal photocoagulation in temporal and more proliferation of the fibrovascular membranes. Again, so on 1st of March, this patient vision deteriorated as well with diagnosis of occlusive vasculopathy, most likely related to TB based only on quantiferon test. So the patient started in 1 agent of anti-TB at that point. Later on in May 11, 2023, the patient situations were get more progress, and there is traction retinal detachment at the macular area, as you see in his OCT, as well the finding of the B scan. So what was the putting of the different, so it was case of TRD, vitreous hemorrhage, macula on with no clear diagnosis yet, vision stable, vitreous hemorrhage present since 4 months. So the patient underwent urgent BRB by the medical team, no need for surgical intervention as feedback from the vitreoretinal surgeons. Later on, if you see his picture, is getting more ugly with more proliferations and vitreous hemorrhage, and mostly the macula is now almost destroyed in this patient. So surgical retina was consulted again, but no intervention was advised, and because according to their justification is that the reason is not known. Well, the case seems for us as Uveitis peoples, this is mostly a case of idiopathic vasculitis with ischemia, proliferations, and mostly with positive quantiferon could be labeled as an Eales disease. So at that time being consulted at this point where I say this patient need an urgent PBV with pre-op intravitreal Avastin, 5 days pre-op, and to start steroid in 40 milligram with other medications. So this is the picture pre-op. After that intravitreal Avastin injections, and patient underwent barsaplan vitrectomy, and the picture as you see here, mostly the area that involves showing subretinal oxidates with remnant of retinal fold, and BRB were applied to all area of that. The vision of the patient improved to 2300 in the first post-op, and this is the OCT starting to see that settle down of the subretinal fluid with just folds of the retina because of long tractions. And this is just only 3 weeks post-op. The vision improved to 2100 with residual, suboxidates and some retinal, folds. So in conclusion, this is a case of vasculitis of unknown origins, only with 1 signs of quantiferon in the labs, were a little bit, delayed in the management because, there is different feedbacks from different groups. So when there is, phytoretinol having, a specialty in uveitis, mostly is having the ability to judge such cases, because leaving this patient without any early intervention might lead to very, poor prognosis. So that's what I would like to say about what the case that I presented, and open for any questions. Thank you.
Thank you so much, Hassan. This is a great case, and I think it underscores why uveitis and surgical retina should be combined. I think it's because yes, I think I totally agree with you. I think earlier intervention may have been better. So any questions from the panel? Dr. Shri, you have something here to say?
I was thinking, have you thought of Cogan's syndrome in this case?
Well, it will be difficult to think in that manner, because the patient's situation is progressing
Rapidly.
as rapidly, and to put the diagnosis of Ill's disease with all finding as ICU negative, so we'll go in that directions. I've been consulted in the last minutes, so I say no, we cannot wait. We have to go in and continue. The most important that, as quantiferon is sensitivity is high, but it's not to the level that you can say the patient doesn't have contact with TB. It doesn't have, somebody in his, as a care provider, so that we can see there is an exposure. So quantiferon, but, we're trying to cover him with one agent and with steroid and surgery. Now the situation is getting acceptable. This case is, I was thinking about in different situation, as there is a spot of retinitis, thinking about the possibility of Bahjat disease. It could be as presented as
yes, of course, of course. But I think you did the right thing. Obviously, this patient still can get more treatment with steroids and anti-VEGF. That would be a great combination. And it's amazing that you had to push the surgeons to do this, because probably any one of us would have been in that eye way like you would want us to be in as soon as possible. That's amazing recovery, though. Fantastic.
And I think so. What's happened is that, phytoretinal surgeons usually are not dealing with these cases as usual.
Yeah.
So they get when they see the mess, it might be going in the opposite direction. So, how much the people looking to have more, better prognosis. So this is why. So experience with some knowledge about uveitis might help in these cases.
Very good.
May I ask a question, Hassan?
Yes, please.
Great case. Alhamdulillah. So you decided to treat this as with the quantiferon positive, and you're thinking that TB has something to do with this. You decided to treat it as latent TB and not give a full treatment because you're thinking that mostly this is inflammatory, or?
Well, it's question mark to be, we label it as idiopathic, first of all, vasculitis, as based on all the investigation. The only one that coming is positive is the quantiferon. But looking for other, possibility of sign that could help, like, positive PBD, CT scan of the chest, an obvious inflammation in the eye, because the vitreous wasn't that badly involved in this case, apart from this vasculitis, as you see. So for that reason, till now, there is no an obvious, document that 100% this is going with tuberculosis. That could be, as we say, that, hypersensitivity to tuberculin proteins. It could be one of the possibilities. And the treatment here mostly steroid rather than to be the others,
Hassan, here we would have pushed for a full TB treatment. So we see these types of patients sometimes, and we label them TB delayed hypersensitivity uveitis, which I think is just the name, again, another name for Ehl's disease. And
and my opinion was, as you say, I would like, but it was just only a few days ago, because I just consulted in the last minute, and the patient already started in one medication. So I started him in steroid to prepare him for surgery, which is important, but anti-TB definitely it is part.
Yeah, and sometimes you get pushed back from the TB people. They don't want to give them full treatment because, like, the only evidence you have is just based on the gamma interferon assay. So
Myself,
sometimes we see
usually I
that
go
as
with
well.
full medications, I just only accepting that giving ethambutol. I give, 3 agents apart from the ethambutol.
Excellent, excellent. So our next speaker is, and our friend is Dr. Rola Hammam, Associate Professor of Ophthalmology, American University of Beirut, Lebanon. Rola, before you start your talk, can I ask you to summarize or to maybe give us like 4 or 5 causes for, in your mind, the most important of occlusive vasculitis or occlusive retinal vasculitis? So I think from those we had TB-delayed hypersensitivity. Dr. Kurup said Behçet. Anything else you can think of, again, for those who are following us?
I can think of lupus.
Yes.
And I mean, sarcoid, I mean, we always think of sarcoid. And an entity I'm going to discuss next.
And maybe, maybe antiphospholipid syndromes.
Yes, of course.
Okay, yes. So that's, okay, Rola, please go ahead.
So this is a case of a 43-year-old male who presented with blurring of vision, bilateral, 1 week duration. It was associated with redness, photophobia, and pain. 10 months prior to this presentation, the patient was diagnosed with HIV and EBV related large B-cell lymphoma. The patient was on treatment for his HIV and received chemotherapy for his lymphoma. The last follow-up was 4 months prior to his presentation to us. And at the time, 4 months earlier, the CD level was high and the viral load was undetectable. The current CD level was unknown. And his last chemotherapy cycle was 4 months prior to his presentation. The patient also had was hepatitis positive, and also on his investigation 4 months earlier, the viral load was undetectable. On exam, the patient had decrease in vision, 20/80 on the right side, 20/200 on the left. Pressures were within normal. The eyes were injected. They had inflammation in the anterior chamber, 3+ cells on the right and 4+ cells on the left with some posterior synechiae. And in the fundus, you can see that there is vitreous haze. And there is this large area of retinitis, looks like granular retinitis with vasculitis as well. This is the right eye. The left eye had worse haze, but you could see also an area of retinitis that you could see temporal that is more hazy here, but most likely similar to the other eye. The FA showed vasculitis in both eyes and a disc hyperfluorescence in addition to the retinal involvement. The OCT, the deep retina was spared. It's clear on the right side because of less haze, so it's a better image. But it seemed that the outer segments of the retina were fine. We knew from the screening history that the patient was PPD negative, VDRL negative. The serology for CMV and toxoplasma were positive for IgG. So given this, the patient was started on valganciclovir oral treatment with Bactrim, and also given intravitreal ganciclovir injections with the impression that this is very likely CMV retinitis. A week later, the patient's picture, we felt that the retinitis might have been a bit better, but the haze was getting worse. Still, the deeper retina was still acceptable on OCT, still was okay. And steroids were added to the regimen, and we had requested with the medical team caring for him a current CD4 level, PCR level of CMV in the serum, another VDRL TPHA, and all those are pending. They were now not out yet. A few days later, there was further deterioration, 2400 vision now, and the clinical picture changed. You can see these distinct lesions in the In the retina, this obliterative vasculitis, there is worsening of the condition and a change in the clinical picture from the presentation. You could also see that the areas that presented with retinitis, and now you just can't see it there anymore. The deeper retina now is involved. There is macular edema. There's disruption of the deeper retinal layer, and the fluorescein angiography now shows a typical leopard spot pattern on the FA. By now, and this is 2 weeks later, the results came back, and VDRL is positive, confirmed with a TPHA, and with the diagnosis of new diagnosis of syphilis. The patient underwent LP, looking for involvement, evidence in the CSF, and VDRL was negative in the CSF. The patient received treatment. Penicillin was not available, so he received ceftriaxone, intravenous infusions for 15 days, and after treatment improved significantly the vision to 20/40, and the clinical picture, the fundus looks much better. So does the OCT. I have a little bit of a revision of the topic. I don't know if we go ahead with that or we go for discussion. Or what do you think?
Well, do you want to show maybe if you have like 1 or 2 slides that you really feel like these are the main ones, and then we can have lots of discussion because it's a fascinating case.
Right. So syphilis was first described by an Italian poet back in 1530 in a poem where he spoke about a shepherd with the name syphilis and had that disease. And the poem talks about how he angered the goddess and she inflicted him with this disease. And the disease gets the name from this shepherd. It was about 1500 later that it was the organism, the spirochete Treponema pallidum, was isolated in 1905. In 1910, Wasserman was able to, by complement fixation, test the blood or identify the blood that is positive for the antibodies for Treponema. And it was about 30 or 40 years later that penicillin was discovered, and we had the treatment, and still the main treatment for this disease. Usually the ocular involvement is in the secondary, tertiary stages. However, it can affect the eye at any level, at any stage. And it's a great imitator, and that's the important point here. It's the great mimicker. It has multiple clinical patterns of presentation. It can affect all the retinal layers. It can affect also, can present with anterior uveitis, but most commonly it presents with posterior uveitis. And it can be any type of posterior uveitis, retinochoroiditis, multifocal choroiditis, multifocal retinitis, retinal necrosis, macular placoid lesions, which are typical. Also, it will be associated with vitritis, papillitis, vasculitis, phlebitis, occlusive vasculitis, and CME, like what we saw in this case. There are the non-specific tests, which are non-treponemal tests, including the VDRL, which is the most common. This is the screening test. We have to keep in mind that it is negative in 30% of latent or tertiary syphilis. And in this case, we had a negative VDRL when it presented to us. Then the repeat testing was different, and also the clinical picture, we're thinking that this is CMV, but then later turned out to be syphilis, this great imitator with a negative originally VDRL. The more specific assays would be the FTA antibodies, and these, when they're positive for life. And this is the confirmatory test, and some people, including me, and I think most of the UVI specialists, when we test for syphilis, and we do that on almost all our patients, we do VDRL and TPHA or FTA antibodies, so that we make sure that the patient, this is on the differential or not. The treatment, as we said, is penicillin. Ceftriaxone is another treatment if penicillin is not available, and if there's allergy, then doxycycline may be given. Systemic steroids for the prevention of the entity called Jarisch-Alzheimer reaction it's advocated to be started 3 days prior and a day to be given for 3 days and to be started before the treatment for syphilis. There is a meta-analysis that discussed the factors associated with the poor visual prognosis in these patients. The longer the time between the onset of uveitis and treatment is a bad prognostic sign. The prolonged ocular symptoms, also macular edema, long-standing optic neuropathy, co-infection with HIV, also is a poor visual prognosis and poor initial visual acuity. Higher success rate of treatment and preservation of vision would be vasculitis, anterior uveitis, and neurosyphilis. Again, the main learning points is that the testing for syphilis, you need both. VDRL is not enough. And look again if the response is not expected, as we all do with these cases of uveitis. Thank you.
Rola, thank you so much. This is a fantastic case. Can I just open the discussion? So we have here a patient who has HIV, Hep B, and lymphoma. And so was there a risk? So how did things happen, Rola? Did he was at high risk for HIV from sexual practice? And then after that lymphoma happened, or he had lymphoma and he just got HIV and Hep B from blood?
Yeah, he presented with lymphoma. It's EBV associated large B-cell lymphoma. So he had probably HIV undiagnosed and then end up with lymphoma. And he presented with the symptoms of lymphoma, and he was discovered to have HIV at the same time.
And was there a history of men having sex with men?
Yes.
Yeah, right. So this is an important point, because then it makes you think of the possibility of syphilis later on when things are not adding on. So although that might be a critical part of the history, but Dr. Rola pointing out here, it's important to know these things. And sometimes it's difficult in the Arab world to know these things, of course. So again, maybe a question to Dr. Kurb here on Dr. Rola's fascinating case. So a patient was in this situation presenting with retinitis. So what's your differential diagnosis in this situation?
Of the lymphoma coming back, but the pattern doesn't support. Then you see these granulomas. They have to be sarcoidosis or syphilis, is one or the other, typically.
Right. So sarcoidosis would be something like another diagnosis. Syphilis maybe in relation to the MSM, and then of course
the shifting patterns and where there's no destruction, because syphilis, those organisms infiltrate, they don't destruct. And the testing, I think the testing what we do now is different. We go to the immunological tests and go backwards. And
so reverse sequence.
Correct, reverse sequence. That has been a little bit more I mean, you hit the nail on the head. You got the diagnosis. You suspected it. It's saved his life, basically, not just his eyes, right?
And Dr. Hassan, so in this context, I would put also toxoplasma in the differential diagnosis, because we know toxoplasma in immunosuppressed patients can present like viral, and actually it may present also like the bit like syphilis, where the lesions heal, where viral retinitis usually do not heal without treatment. Dr. Hassan, would you put toxoplasma in this context in the differential as well?
Yeah, I put it because a typical case in a double shot immunocompromised patient, in chemotherapy for lymphoma, as well is known to have HIV. So this is make the atypicality of the. But even though Dr. Hammam, she did VDRL in the first shot, but even though VDR maybe at the transitional stage, not reflecting the disease itself, but patients with these situations, syphilis, especially nowadays, we have a surge of these cases over. I thinking that when I saw it, that's about possibility of posterior syphilitic blacoid lesion, not that typical of posterior ball involvement, just only in the embryo. So if that chance to have wide field OCT, it might be sure, especially inner retina is not that obviously involved in the early stage. So syphilis is there, even though cannot be ruled by labs, but I will put it in my mind.
One point in this angiogram is that there's so much inflammation that it's unlikely that this patient is not immunocompetent. Because if you're immunocompetent, you wouldn't expect so much inflammation and the optic nerves bilaterally light up for, say, toxoplasmosis or something like that. It would not add up in my experience. I think
Yeah,
all
completely.
Armando, you had some experience with this, right?
Yes, definitely. But I agree with everything that's absolutely been said. But it's also always important to remember that pretty much every case of uveitis should be screened for syphilis.
But,
It can,
yeah.
that's pretty much it. You know, it can always be syphilis.
Now, JP Dunn published a very ugly looking syphilis, I think 2 years ago, as a case diagnosis, and it was hemorrhagic, just like your case here. But those granulomas are typical for infectious disease, and it's very difficult, right? What does Rift Valley look like in an immunocompromised? Could you tell us a little bit about those conditions?
I think we have to move for the sake of time.
Okay.
So I think that's a good point. We probably will need to touch on that Rift Valley and Rift Valley on the immunocompromised.
Yeah,
so our next speaker is Dr. Sri Kurup. And Dr. Sri is a great friend, and he's the retina uveitis head in Cleveland Hospitals, Cleveland University Hospitals in Ohio.
Are you able to see?
Not yet. Yes, we can see your second slide. Yes.
Okay, let me get this first slide. How about now?
Yes, fantastic. If you can just make it bigger.
All right, good slides. Let's start the slide.
Press the little presentation button there, then.
You got it?
Yes.
There you go.
Good.
Yes, excellent. Thank you so much.
So thank you for allowing me to be here with friends and your family, right? Literally. So I saw this patient because I was walking in the corridor and a cardiothoracic surgeon told me, a very well-known guy, I have this patient who's having these visual symptoms. Can you take a look at this? And I said, okay, let's do that. So she's a 45-year-old female artist, and she does landscape. So she's very cognizant of the periphery, peripheral vision, etc. And she has been getting treatment for chronic endocarditis, bacterial, on IV antibiotics at home for 3 months. 3 months. And she has cycled through 7 cardiologists in various hospitals in Cleveland. So the last one referred this patient to the cardiothoracic surgeon because he is probably one of the best surgeons there to do a valvectomy. Now we're talking about the aortic valve valvectomy. So it's a big deal, right? In a patient of this age, because you need a synthetic valve. So this is a corridor consult. I saw this patient. I don't know how much you can see here, but infratemporal in the right eye, there's a little retinal hemorrhage. And I'm going to make it a little. Left eye is not so much. Do you see that now? Infratemporal in the macula. It's a retinal arterial hemorrhage. So I saw this. And the left eye, the vessels in the periphery, a little tortuous. So this was during COVID, like was ending in this, so to speak. And I asked her, how did you come here? Because she looked very fine, you know. A chronic endocarditis patient is typically quite sick. So she said, I walked up. I said, you walked up 3 flights of stairs? She said, yes. So I told her, you don't have bacterial endocarditis. I don't know what this is, but this is not endocarditis. So it's kind of interesting, you know, you have an eye doctor telling the patient this, and she said, all right. So we did an angiogram. So the angiogram shows, if you look in the temporal periphery, infratemporal, there's vascular leakage, both venous and arterial. There's arterial occlusions. This is the left eye. Left eye, she's got some vascular events in the temporal periphery. So you have essentially a young lady with peripheral occlusions, arterial and venous. She jogs, she takes antibiotics and she jogs. She had a DVT-like episode 2 times, suspected. So I said, okay, let's start investigations. And we had a diagnosis. We recommended. So I saw Alan. And I said, Alan, you know, get the valve out. So very, very interesting, right? This patient was seen by, this is the valve, aortic valve. So this is how it went. Patient goes to cardiology. Patient goes to cardiologist 7 times. Patient goes to cardiothoracic surgeon, sees a uveitis guy in the corridor. The uveitis guy talks to the cardiothoracic surgeon. The valve is out. It's amazing how much trust he had in me. So I was glad I was right. So we published this in JAMA, and it was nice to get a publication in JAMA and talk about, this is the doctor who did it, Markovitz. The person who wrote this paper is actually the pathologist, Miroslav. He wanted to send this to JAMA. I told him, I don't know, but apparently JAMA likes these type of entities that affect the heart and the eyes and can kill the patient. So just a pour. So this is APLS. We all know this, what's going on here. And it is present in a lot of patients with miscarriages, and we probably are missing it. So if you see young patients with DVTs or strange vascular symptoms, always think about APLS. Thank you.
Thank you so much, Sri. That's a fantastic case. So I think we were talking about occlusive vasculitis and vascular occlusions. And we talked about several things: TB, delayed hypersensitivity, Behçet, lupus, SUSAC, and again, Dr. Rolla as well told us about the syphilis, syphilitic uveitis, and viral retinitis. And here as well, don't forget antiphospholipid syndromes as well. This is a fantastic case. So, Dr. Samir, any comment on Dr. Kurup's case here?
Thank you, Ahmed, for the invitation. Really, it is very nice and interesting case. I think it's very rare, but we have to put this in the differential diagnosis of vasculitis. So as you mentioned, when I see a case of retinal vasculitis, here, at least in our region, I think of TP, sarcoidosis, Behçet's disease. So if all these come out to be negative, I have to think of the of rare cases like this. But it's a very nice case, actually.
Fantastic. Okay, Rolla, any comment? Quick comment on Dr. Kurup's case?
It's a great case. I think the take-home message is we are ophthalmologists, uveitis specialists, but we're physicians, and asking the patient, how did you come here? You walked up. Okay, so probably this is not endocarditis. That's very good, and it's a lesson for us, all of us, to learn that we could save a patient's heart with these simple questions, a patient's life.
Excellent.
So I have to thank AUB for a lot of my present publications, because I worked with Manzoor.
Yeah.
Yes.
It's a great university with Rolla and Dr. Mansour there. It's just it's a fantastic university, really.
Yeah.
So I think maybe the message as well: spend more time in the corridor, because then you can diagnose cases and get JAMA publication. So with that being said, we'll move to our next speaker, Dr. Armando Oliver. Armando is the head of the department at Puerto Rico, and he's a uveitis and surgical retina specialist. So Armando, thank you so much for being here.
Thank you so much, Ahmed, and thank you, Dr. Mohamed Al-Amri, for the invitation. Good morning to my friends in America, and good afternoon to my friends in the Middle East. This case, we're going to call it shotless vasculitis. These are my financial disclosures, which are not pertinent. This is a 27-year-old Hispanic female who complained of photopsias and floaters of 1-year evolution. She had a past medical history of Hashimoto's thyroid disease. Past social and family history was pertinent for a history of cancer in the maternal grandmother, and the reveal system, she had some history of hypoglycemia. Her best corrected visual acuity was 20/40 in the right eye and 20/30 in the left, and the anterior segment examination was pretty much unremarkable. The fundus exam, she had some mild vitreous debris and 2+ vitritis, and we could also notice some pretty venular sheathing in both eyes, which was more evident when we did this fluorescein angiogram. And the fluorescein angiogram revealed this branching pattern of vasculitis as well as some macular leakage consistent with her CME. We did an ICG, and the ICG did not reveal any hypocyanescence spots suggestive of choroidal lesions. We only had some blockage from the vitreous debris. And of course, the OCT showed cystoid macular edema in both eyes. We did a workup. We did, in terms of radiology, we did a whole body gallium scan, and it showed that the inflammation was localized to both orbits. However, a bone scan did reveal some arthritic changes, non-specific to the interphalangeal joints of the first finger, left hand, and some in the right ankle. As far as blood work, we did a test for syphilis. Both FTABS and RPI were negative, and the quantiferon TB Gold Plus test was also negative. However, she was HLA-A29 positive. So how do we call this? We call this HLA-A29 associated retinal vasculitis without choroidal lesions. As far as treatment, we started her on prednisone 60 milligrams per day and CellCept mycophenolate mofetil 1.5 grams twice daily. That only allowed us to achieve partial improvement. So while on prednisone 60 and CellCept, we added adalimumab, and then we were able to taper her steroids a little bit. However, when we reached the 20 milligram dose, she developed bilateral CME. We treated her with intravitreal dexamethasone implants, but she was a steroid responder. So at that point, we switched her to Actar, which is a repository corticotropin injection, which resulted in resolution of her macular edema, and we were able to discontinue the systemic steroids and the adalimumab while keeping her on CellCept. At 2 years follow-up, her visual acuity was 20/20, slit lamp exam was normal. However, she did have some low-grade recalcitrant inflammation in both eyes, which we're still dealing with and consider other immunological agents. As you all know, Birdshot retinochoroidopathy was described in 1978 by Ryan and Momini. It's characterized by multifocal choroidal lesions, cream color white dots scattered through the fundus. It can have retinal vasculitis. It usually, patients go blind either by centripetal visual field loss or macular edema, and usually requires quite aggressive immunosuppressive therapy. And the HLA-29 class 1 antigen conveys a very high relative risk for this disease. HLA-29 associated retinal vasculitis without choroidal lesions is an entity that we believe shares many of the clinical features of Birdshot, as vitritis, macular edema, optic disc swelling, visual field constriction, and it also usually requires aggressive systemic immunosuppressive therapy. We reviewed 4 cases between our clinic and Minnesota, and we found that the average median age of presentation was 40 years in a range of 14 to 71. Most patients were female at presentation. All 4 patients had a visual acuity of 20/50 or better. All the eyes had mild vitritis. 3 eyes had cystoid macular edema. 2 eyes had optic disc swellings. And all patients required treatment with systemic steroids and aggressive immunosuppressive therapy. To give you an example, figure A is our patient, and figure B is a patient with Birdshot. This is the angiogram of both patients. And based on the angiography alone, it is really hard to tell which one has HLA-A29 associated retinal vasculitis without choroidal lesions and which one has Birdshot, typical Birdshot with the choroidal lesions. So to conclude, HLA-A29 associated retinal vasculitis without choroidal lesions appears to share many of the clinical features of Birdshot chororetinitis, including the need for aggressive immunosuppressive therapy. Whether this entity represents an early form of Birdshot or a more localized variant of the disease is a topic for further studies and my very intelligent friends who can probably figure this out better than I can. Timely identification of HLA-A29 genotyping in patients with retinal vasculitis may allow you to make this diagnosis and prevent peripheral further visual loss, either from the chronic cystoid macular edema or visual field constriction. Thank you so much.
Thank you.
Armando, this is a great case. Armando, can I show you? Can you go to the ICG picture?
Yes.
The second one, I think there are small choroidal lesions there.
You think so? Let's see.
But again, I'm not sure really. Here,
are those? Those are
Floaters.
Yeah, the ones in the macula. Yes,
Yeah,
here.
in the right eye, I think that's blockage from the
Floaters.
floaters.
Are they
Because
okay?
blocking
So
the
when you
vessel.
looked at the color
Yeah,
picture,
and if you look at the late ones, they're not there, and it's moved. So
And it's
yeah, and I
blocking the
think
vessel,
on the
right? You
I
can see
wonder
it's
on the
blocking the
left
vessel.
in the macula if there are some as well. It just sometimes if you have Heidelberg, sometimes you actually get better with the ICG, but even if they are present, it's like very minimal, not what you expect to see.
mhm.
Yeah, I have a case like this. If you haven't published your series yet.
Yeah, I
We
have a case
submitted
also.
last week. It would have been great to include you, but yes,
Hopefully it doesn't get declined. If it gets declined, let us know.
we'll add you. Thank you.
Yeah, so I have a case, Armando, where I saw a patient who is coming with what looked like a granuloma in the macula and had one nasal birdshot lesion, one lesion in the other eye. So the patient was sent as a macroaneurysm to give you an idea to me.
Mhm.
So I asked the guy's history. His father has birdshot. His father's getting treated for birdshot. So there are some people, when you think of all the immune conditions we have in the body, how can it be that everybody with A29 will only present with lesions in the choroid and lesions? It's just impossible,
Yeah.
right? And how can you
That's
say
a good
everybody
point.
is going to need treatment? There'll be many
It's,
people who have very mild disease too. Like Susan Lightman talked about that, I think.
Yes.
I believe it's probably a spectrum. And if you look at PubMed, you'll find that half people call it retinochoroiditis, the other half will call it chorioretinitis. And they're probably both right. In some people, it may be a chorioretinitis.
Right.
In other people, it may be a retinochoroiditis. And some people, it may just stay predominantly as a vasculitis. So probably we have a birdshot spectrum, and we don't know it because many people just don't check for HLA-29 on patients with retinal vasculitis. That's probably the
Yes.
main.
What about the rest of the panel? Do they have any cases like this? Because we can put it together.
Yeah, I was going to ask Hassan, Dr. Hassan, if you're here.
Yeah, I'm hearing you. Yeah, it's really,
Yeah.
and for us, it's very rare to have birdshot in our area. Maybe Dr. Hamaki knows that. It's too difficult to have these cases. When I look for the case, oh, this is typical case of, fluorescent angiography of Paget disease as you have it, diffuse leakage, Verne-like with the macroedema. So that's my thinking, And when I
Right.
saw that the HLA-29 is positive, I'm starting to get drawback for that. So really, I don't have a case like that. And I did a lot of HLA screening for my patient, and actually we don't have this entity.
And one last comment that if you look at the old literature, I think it's probably a little bit racist because they thought that this was something that would only happen to white people. And I've seen papers that say this is a predominantly Caucasian disease. But then we had two cases by Debbie Goldstein, one in a Mexican, another one an African-American patient, that they were being treated for something else because they thought just because he was Mexican and the other one was African-American could not have birdshot, and they were HLA-29 positive. And then we just published a series in Puerto Rico. So it's, it could be, it's disease has no racial boundaries, but.
Roland, do you have a quick
About the
comment before we move on with Dr. Samir presentation?
Yeah, a couple of quick things. One, because it's, probably it's uncommon everywhere, but because it's uncommon, unless I see the typical fundus picture, I don't order A29. So I might be missing some. My question is, what about the visual field and the ERG? Do you use those in your Dr. Armando, did you check those and they were normal in this patient or?
No. My first patient ever, she had very mild vasculitis, but she had visual field constriction, which led me to treat her. And that was like 12 years ago. So they too have visual field constriction as other patients with birdshot.
Yeah,
one more
great
comment.
points. I'll summarize, Dr. Hassan, go quickly if you.
Just only to look for the, the treatment response, how it was.
It's very bad treatment response, just like Bershad, very hard to treat. They're recalcitrant to probably prednisone and Celsep. I think they would probably do great with an intravitreal fluocinolone implant plus another immunosuppressor, but this one was a steroid responder, so that's a path we could not follow. I'm probably going to change to tocilizumab and see what happens. She was a law student, so she was finishing that, and she didn't want to try new medications while she was finishing. So we'll probably do tocilizumab. I think she started that recently, this particular case. But the others, same story from my friends in Minnesota. One of the patients who was a child, she required anti-TNF agent to be able to be weaned off the rest of her medication. So it's very aggressive.
That's great. Yeah, it's as you say, it's a spectrum. Our next speaker is Dr. Samir Shauki from Egypt. Samir, thank you so much for being here with us, and we look forward to your talk.
Thank you very much, Ahmed. I think it's okay now. It's working.
Please go ahead. Go ahead.
Okay. Thank you so much. I would like to thank Ahmed Salam, my friend, and Dr. Amri for the kind invitation. Today, I will talk about two interesting cases that were initially misdiagnosed, if the time allows. The first case, I'm sorry, it's not working. Just sorry, it's okay now?
Yes. If you can make it bigger, if it's possible to make it bigger.
Yeah,
presentation mode.
Presentation mode down there. I think it's down. It should be down. The icons down next to focus there, like down.
Sorry. Seems.
Can you please press on slideshow? It will be okay. Slideshow.
Or a slideshow.
Where is
it
it?
available on the top? On the top? No, not in the presentation. Yeah. On the left side. On the top left side, over the maximum over of here. Yes. Go to the right side, little bit. No, to the right. Yes, this one. No, it was there. Slideshow.
No.
There was a slideshow.
Please accept the request, sir. You might be seeing a request.
Can you accept his request? He will arrange that very fast.
Sorry. Yeah.
Accept the request.
Okay, that's fine.
There you go. Fantastic.
That's fine. Okay, thank you. Sorry for that.
Yeah.
So this is a 37-year-old male patient who presented on 18th of April. He was complaining of severe headache for 2 days and blurring of vision and floaters in both eyes. His vision was 0.1 in the right eye, 0.05 in the left eye. The intraocular pressure was almost normal. Examination of the anterior segment of both eyes showed 2+ cells and 2+ flare with irregular pupils. Fundus examination revealed these findings. It showed this vitritis and hazy view and this foci of retinitis. Fluorescein angiography showed this hot discs. He was seen elsewhere and was diagnosed with optic neuritis and panuveitis. Review of systems at that time revealed history of recurrent oral ulceration and genital ulcers. So putting these things together, the panuveitis, optic neuritis, oral ulceration, and genital ulceration, the patient was diagnosed as having Behçet's disease. He was given steroid injection, oral steroids, 40 milligrams, plaquenil, azathioprine, and cyclosporine. He was heavily immunosuppressed. However, there was very poor response to this systemic therapy, and they were considering him to start biologic therapy. However, despite this heavy immunosuppression, the response was poor. The patient has optic neuritis, panuveitis, and was suspecting of having Behçet's disease. So in this case, we have to think of other causes. We have to revise our diagnosis. So I started to think of infectious etiology when presented to me. So I asked him, did you have any fever before presentation? He admitted that he had a fever before the development of the eye manifestations. I asked him the question that Ahmed and Rula were discussing. Did you have any sexual history outside marriage? He admitted that he had a sexual relationship. So I asked him about skin lesions. He didn't mention anything, but when I put him on the slit lamp, I noticed that he has this characteristic lesions in his hands, and I asked him to show me his legs, and I saw this skin lesions. So I suspected syphilis, and I asked him to do syphilis serology, HIV antibodies. And also to rule out other important causes, I asked him to do quantiferon, ACE, and CBC differential. Laboratory workup was almost normal. The CBC differential was fine, the quantiferon was negative, and the ACE was within normal. However, HIV came out to be positive and syphilis serology was negative. He was referred to Alexandria Fever Hospital to start antiretroviral therapy. However, he came after 3 days and his condition worsened with the development of hypopyon now. So I started to think again of syphilis. So the condition is worsening. So I called one of my dermatology colleagues and he asked me to repeat the syphilis serology again because of the sometimes when the patient have high antibodies against syphilis and co-infected with HIV, there is the prozone phenomenon. And I ordered it again and came out to be reactive. So that our diagnosis was HIV positive and syphilis positive patient. This is very interesting case in our region because as Ahmed and Rola were discussing, this is relatively rare in our region, especially here in Egypt. But I saw 3 cases in 1 month. So I think we have to put syphilis serology again in our patients. So I have another case, Ahmed, if you like.
Yeah, I think we're good. Yes.
Okay. The second case is a 23-year-old male patient presented on 15th of February. He was complaining of blurring of vision in the left eye since 2 months following fever. His best corrected vision was 0.4 in the right eye, count fingers at 2 feet in the left eye. The anterior segment of the right eye was normal. In the left eye, there were only trace flare. Fundus examination revealed this bilateral disc edema, and this in the left eye, there is a macular star configuration. Fluorescein angiography showed this disc staining, and he was diagnosed elsewhere as having papilledema, and they didn't pay much attention to the macular star configuration, and they asked for the OCT retinal nerve hyperlayer, and the report came out to be bilateral severe papilledema and left associated macular scar. His treating doctor, as usual, and it's a normal thinking, is ordered MRI of the brain, and unfortunately he did lumbar puncture. MRI of the brain was normal, and lumbar puncture showed normal opening pressure of the CSF, and it was normal. So again, when he presented to me, I started to think again. He has optic neuritis and macular edema, so he has neuroretinitis. So I started to think of the important causes of neuroretinitis, and I asked him to do the visual fields. The right eye showed enlargement of the blind spot. The left eye showed altitudinal visual field effect. I ordered the essential lab workup. CBC was almost normal. The quantiferon was fine. And interestingly, Bartonella antibodies were positive. So the take-home message in these cases is to think of infection if there is poor response to conventional immunosuppressive therapy in cases of uveitis, and not every case of disc swelling is papilledema, and careful history is mandatory, and we have to ask a patient about sexual history. This is very important, and always be ready to change your diagnosis. Thank you so much, Ahmed, and my colleagues.
Samir, thank you so much. Samir, do you mind putting your slides of the syphilis case, the fundus photo? It just would be good to get some conclusions about how to manage retinitis. I've just heard from Dr. Amri that we have a few more minutes, and I think the discussion is fantastic.
So this one?
Yes, I think these are fantastic. So, Rola, what we've learned from those cases, the 2 cases, is reverse sequencing testing, like we do in the States here, but not in Europe and the Middle East, or maybe order the 2 tests together, like antibodies and RPR. Anything else you want to say on this point?
No, I think it was mentioned before. I think it's very important to test for both together. And the other thing is we have to test it on every patient. Almost every patient who comes to us needs to be tested, especially in this case. I mean, this is an HIV patient, and it just makes sense to test it immediately. And I think infectious diseases doctors who are taking care of the HIV, you would think they would have done that automatically with the diagnosis of the HIV.
And I think also ask about sexual history and social history, sometimes embarrassing, especially on our side of the world or on the Middle East side of the world. But it is important because, I mean, I first establish a relationship with a patient and then ask them the personal questions. And you can maybe like, give them a warning shot that will ask you personal questions. We're not judging, but we
even
want
if
to
they
know that.
deny it. Even if they deny it, you have to test it.
Yes. Yes.
Yeah.
Okay. So so Dr. Hassan here, this is patient with these lesions there. Some of them are retinitis and some of them are vitritis and the papillitis. So what's your differential diagnosis of retinitis? So how would you, for example, if you're teaching your fellow, what are you going to tell them about
Initially that
retinitis?
infectious causes should be ruled out, especially in young patients, as usual in uveitis. Syphilis test, I would like to stress over not just doing just RBR or VDRL. Usually we have to have, both tests, to look TBHA and VDR. RBR is an essential to do it. In this patient where I'm so that temporally in the left eye, I'm seeing some sort of like placoid lesion temporally, and that could be suggested. But in these cases, usually syphilis is an important, we have to rule it out. The papillomacular rash that I saw, it might be, one of the means of transmission of the disease, especially when it's starting to be dried up. This is an important. This could be one of them of the transmissions, apart from the sexual contact.
So I have a comment, Ahmed, please. This patient was diagnosed and treated elsewhere as having Behçet's disease because of the retinitis, and he was given immunosuppression. So that's why when we ordered the test, it came out to be HIV positive and syphilis negative, and then we repeated the test. The question now is for our colleagues in the Arab region. So traditionally, we ask the patients in our region to substitute, and also our colleagues, our young colleagues, to substitute syphilis serology with a tuberculin test, as it is more common here, and it is a great mimicker. I worked in Saudi Arabia for a long time with Professor Khalid Tabara, and at that time, the syphilis was not common. My question to Dr. Dibi, do you see many cases of syphilis in Saudi Arabia now?
Yeah, me too. That's a good point that you mentioned. In Saudi Arabia, before 2018, mostly we don't have a lot of syphilis cases. After, the COVID, we start to see these cases. In the past, as a rule and baseline in our, tertiary hospital, we do syphilis. Although we never had cases except for endemic syphilis, Vegels, about Vegels. Yeah, Vegels. But this is usually doesn't have this, picture or evaluations, So syphilis for us is one of the essential, lab investigation we do it. Even though that, in our communities, we are a little bit, society that restricted a bit. But after, COVID, we have a lot of search of cases.
Exactly.
Until now, I have more than 12 cases over just the last 2 years.
Also, Dr. Hassan, those drug abusers also have the HIV and more liable to have this, and this is increasing. Rola, what about the cases of syphilis in Lebanon?
Yeah, it's similar, I think, everywhere, although it's, you could see it increasing or decreasing, but it's a very small percentage of our uveitis patients. And I think this is everywhere. But I have one comment about your case, that the photos you showed us of the rash on the palm of the hands and the sole of the feet, that's typical of clinically, that's typical of syphilis.
Exactly. Yeah, agree with you.
Irrespective of the VDR.
So, Samir, can you show the pictures, and can maybe Rola tell us what's really typical again?
Okay, which the skin lesions, you mean?
Yes, if you can, would be fantastic.
Yeah, sure. Yeah. So this is the hands.
It says a maculopapular rash with the scales, and it's at the palm of the hands, exactly, and the sole of the feet. And this is a text. These are textbook pictures of
Exactly. Yes, exactly.
Yeah.
Was it
For that-
itching? It's usually that classic teaching that are itching. Were they itching, or Samir, do you remember?
Sorry?
Were they itching, like were they
No, no,
pruritic?
no. He didn't show me this. I discovered them while I was putting the patient on the slit lamp. I noticed this lesions in his hand, so I asked him to show me his legs. That's why but he didn't complain. It was not itching.
It's not itchy, and now it is now, there is, two parts, the erythema and the dried part of the lesion itself.
Yeah.
And
Yeah.
this is why important at the examination, your gloves and taking care, it's important.
But yeah, yeah, exactly. Let me tell you something also. When I tested him for the first time and he came out to be syphilis negative, I looked at the literature. I saw that sometimes HIV can cause some similar lesions, some skin lesions, which could be mistaken for the syphilis. So we have to put this in consideration also.
I had a question for the panel here. I have a patient who got injected with steroids, bilaterally, intraocular steroids, with syphilis and HIV. It's a long story. Patient came to me. I rescued the patient, but he had steroids still in the eye. And I was contemplating, should I take it out or should I not take it out? So now you think you treat this with antibiotics, you don't need to take the steroids. But the interesting thing is, once the steroid went away, he started getting uveitis. He started getting inflammation in the AC as well as retinal vascular inflammation. Have you ever seen that? I mean, I've never seen syphilis act. It's a non-immune trigger, essentially, right? But in this case, I thought it was, and he's immunocompetent, like he's not, obviously he's producing enough cells to create an inflammation. Has anybody seen this where syphilis, like TB, syphilis behaving like TB?
Yeah, I've seen something like this. It's the other way. So we had patients with syphilis who, after treatment, had significant inflammation that did not go away with anything except intravitreal Ozurdex. And
we need to write about this.
Pardon?
We need to publish this because
yeah, we've published that. We published there were 2 cases. So, and I think the take from that, once you treat syphilis, as long as you can in a way guarantee that they don't have reinfection because of their lifestyle, they may have reinfection. So at least maybe before doing it, just retest the RPR.
yeah,
They do very well actually with steroids, as long as they have been treated. The problem is untreated patients.
Yeah, this
And
guy
to answer
is negative. We tested him.
To answer Sri's question, there's an entity called syphilitic autoretinopathy, which I suspect is probably mostly autoimmune. I did a review of the literature for syphilitic autoretinopathy. In many cases, actually had received steroids, systemic steroids, prior to being treated for syphilis. And there was some improvement. It's just that the workup came back positive and then they ended up treating them. So there certainly is an autoimmune component to the syphilis spectrum of diseases. However, I would not advise someone to treat syphilis with steroids. Of course, you need penicillin.
Yeah. So
I think we'll
if
have
you
to
have the panel has cases, please send me an email or something. Maybe we can write.
Yeah, I think this is again one of the function of these talks 3 is connection and communication and collaboration. So I can share the email of all of us. I think I've sent an email with all of us on it, but I'll do that again. I think we'll have to conclude for the sake of time to keep Dr. Al-Amri happy and the meeting going well. And maybe as a conclusion, it's important to ask history for uveitis patient. So social history and sexual history needs to be asked in all cases. And we talked about reverse sequencing. And Dr. Adibi told us in any retinitis, you have to rule out infection first before concluding that this could be Behçet, or maybe later on along the line, it could be a lymphoma. So retinitis, rule out Behçet. So I just want to finalize here by thanking our panel. This is a great discussion, and I've learned a lot personally. I would like to thank Dr. Hassan Adibi from Saudi Arabia, Dr. Rola Hammam from Lebanon, and Dr. Kurup from Ohio, USA, and Dr. Armando Oliver from Puerto Rico. And last but not least, Dr. Samir from Egypt. Thank you so much all for a great session.
Thank you. I learned a lot.
Thank
I really
you.
appreciate this.
Thank
Great
you.
friends.
Thank you so
Let's be in
much.
touch.
Thank
Back
you.
to you, Dr.
Thank
Amri. Thank you.
Thank you very much, everyone. Thanks a lot.